My name is Cliff Rosendahl, and welcome to this presentation on chaos, clues, and exceptions. This method was first published in 2012, and for more than a decade now, it has served clinicians well, mainly because of its simplicity and the fact it can be incorporated into routine practice with just 4 simple steps. Now, the posters presented here are formatted to be used as a companion to the book Dermatoscopy and Skin Cancer, second edition, published in 2025. You can see here that Chapter 6 covers this subject. The rest of the book is a foundation. It explains the histological correlations of the various dermatoscopic features and goes into more detail with respect to various types of lesions. The first step in this method is to decide whether a particular lesion is a lesion of concern. Can I make a confident, specific, benign diagnosis by dermatoscopic pattern recognition? If the answer is no, then apply the algorithm. We need to practice looking at normal lesions to get good at recognizing immediately if a lesion is one of the 5 common benign categories: nevus, benign keratinocytic, such as seborrheic keratosis, dermatofibroma, hemangioma, or sebaceous gland hyperplasia. Also, any elevated, firm, and continuously growing, or EFG lesion, whether pigmented or non-pigmented, should be excised, primarily to confirm or exclude nodular melanoma. This EFG principle takes priority over any algorithmic method. The second step is to decide whether there is dermatoscopic chaos. Malignant cells defy natural law, and asymmetry is a part of all algorithmic methods for pigmented skin lesions. Now, in the examples given here, lesions A to C are all biologically symmetrical. The shapes may vary, that doesn't matter, but they have one pattern or more than one pattern, symmetrically combined, one colour or more than one colour, symmetrically combined, and one border. So the border is either uniformly abrupt or uniformly gradual. The lesion on the far right, D, is chaotic. The pattern on the left is different to the pattern on the right. The colours on the left are different to the colours on the right. And the border on the right is abrupt, and on the left is gradual. Step 3. If a lesion is chaotic, we look for one or more of 9 specified clues to malignancy. Now, in fact, if you specifically look for the first 2, you should be able to recognise the others if they are there without having to remember each one of them, because they are all objective clues. So, clue number 1, grey or blue colour. You should always consciously look for grey colour in any pigmented skin lesion of concern, because grey is the most sensitive clue and is present in most pigmented skin malignancies. In this case, the lesion shown on the right has a very blue, evident blue colour. It's an invasive melanoma, and the blue is due to melanin in the deep dermis. Clue number 2, structureless eccentric area. Structureless means there's no basic structure predominating. It must not be skin coloured. Eccentric means it must be to one side, not at the centre. And it must be in opposition to a structured area, in this case a pattern of reticular lines, or it must be in opposition to an area of distinctly different colour. With respect to area, it must be sufficient area to break the pattern, so approximately 20% or more. If you have too small an area, you'll find a structureless eccentric area in every lesion. Clue number 3, clods black peripheral. Now, black clods can be seen centrally in the irritated nevus, but when they are located at the periphery of a lesion, that is a clue to malignancy, which is explained in the book Dermatoscopy and Skin Cancer. Here you see the red arrow pointing to 3 peripheral black clods. Clue number 4, lines thick reticular. In benign lesions with the network, the reticular lines are thinner than the holes that they surround, as you see on the right-hand side of this lesion. However, where the yellow arrow is pointing, the lines are focally thicker than the holes that they surround, which points to malignancy, particularly to melanoma. Clue number 5, lines radial segmental. When lines radial are circumferential, that is not a clue to malignancy, but when they're segmental, it is. On the top right, you can see the left-hand black arrow pointing to lines radial segmental extending from an area of the lesion just as dark as the lines. That's a melanoma in situ. Whereas on the lower lesion, you can see the black arrows pointing to lines radial segmental, which extend from a hypopigmented area, which is what is expected with a basal cell carcinoma. Whereas in squamous cell carcinoma in situ, the pigmented variety, the radial lines are made up of dots in linear arrangement, as you see the black arrows pointing to here. Clue number 6, lines white, is an important clue for malignancy and can be polarizing specific or non-polarizing specific. On the right image, you can see polarizing specific white lines, which are bright, orientated at right angles to each other but not crossing. And these are commonly seen in the malignant conditions of BCC, in which case clues to BCC will be evident, or melanoma. And they can also be seen in the benign conditions of dermatofibroma, Spitz nevus, and lichen planus-like keratosis. So the context is important. In a chaotic lesion, melanoma should be suspected. Lines angulated. You can see here in this lesion, you can see the large footprint of the angulated lines compared to the very fine footprint of the reticular lines, which are also present. The angulated lines are believed to be due to melanophages lining up along the lymphatics of the vascular plexus. Now here's an example of lines parallel on the ridges. Now this is on the sole of the foot. The lines are broad, which is what you see when the lines are on the ridges. It doesn't matter where the pigment is, it matters where the lines are. And if you refer to the book Dermatoscopy and Skin Cancer, you'll see the comparison with the fine lines of the dermatoglyphic furrows. This is a melanoma in situ. And lines parallel chaotic on the nail plate, indicating a melanoma in the nail matrix. Now, in this particular case, the lines are chaotic. They're varying in width, interval, and color. But it's really important to understand that that is not necessary. In fact, any longitudinal melanonychia, chaotic or not, arising in a single nail, that's 1 out of 20, after puberty with progressive widening requires consideration of nail matrix biopsy. Now you can see here some examples from the book Dermatoscopy and Skin Cancer. On the upper panel, the lines are not chaotic, they are even, but this is a melanoma in situ of the nail matrix. The final clue is vessels polymorphous, and this refers to the presence of more than one pattern of vessels. Now, in this particular case, there's a pattern of linear vessels, and on the far left, you'll see a pattern of dot vessels. This combination is highly specific for melanoma, and this, in fact, was a melanoma invasive. Finally, we come to step 4. Is there one or more of 4 specified exceptions? Step 4 is reserved for lesions which have escaped excision biopsy based on chaos and clues. Firstly, this can happen when a lesion of concern does not have chaos. Secondly, it can happen when a lesion of concern is chaotic but doesn't have any of the 9 clues to malignancy. The first 2 exceptions apply to any lesion, whereas the second 2 apply to site-specific lesions, firstly on the head or neck and secondly on the palms and soles. Now the first exception is a changing lesion on an adult, and this can apply to any lesion on any part of the body. That change may be confirmed by monitoring, It may be confirmed by the patient's history, or in this particular case, it's confirmed by the presence of peripheral clods. The presence of peripheral clods is a dermatoscopic clue to change, in this place, of an invasive myeloma which is perfectly symmetrical. And the second exception is any nodular or small lesion with any clue. Now, this is because nodular myelomas, sometimes when they're very young, do not have chaos, and also because very small myelomas, because they're very young, may not have chaos. We do not define the upper limit of small. It used to be 6 millimeters, but now we leave that to the discretion of the clinician. Here we have a lesion on a lady, a middle-aged lady. It's on her chest. It's only 3 millimeters in diameter, and it was only discovered by retracting the bra. And it has the dermatoscopic clue to change of peripheral clods, but it also is a small lesion and the nodular lesion, with one of the clues, one of the 9 clues, being grey colour. And this was a nodular melanoma with a Breslow thickness just under 1 millimetre, 0.9 millimetres. Here we have a pigmented lesion on the earlobe. It doesn't have the border of a solitarigo or a nevus, so it's a lesion of concern. And it has pigmented circles, being a lesion on a special site of the head and neck, melanoma in situ. Here we have a lesion on the sole of the foot of a middle-aged patient, which has escaped excision biopsy on the base of Carcer clues because it's perfectly symmetrical. However, it is a volar lesion with a parallel ridge pattern, the broad pattern of the pigment on the dermatoglyphic ridges, melanoma in situ. So, that's chaos, clues and exceptions, a very simple method, a very effective method, and a method which is explained in detail in the book Dermatoscopy of Skin Cancer, a handbook for hunters of skin cancer and melanoma. Thank you.